particularly delighted to be able to introduce and welcome our keynote this morning, Melissa Stafford Jones. Melissa has a long career in service to the Medi-Cal program and to the most vulnerable populations that the Medi-Cal program seeks to serve. Many of you, most of you, I know Melissa. Melissa has served in numerous leadership positions, including the public hospitals. First 5, she will go through her illustrious career of service, of material service, in aid of better outcomes for the most vulnerable populations that we all serve. I think that Melissa's comments today and her new role, of course, are particularly impactful. Melissa's new role is in connection with the Child and Youth Behavioral Health Project. She'll talk about that. But before I turn things over to her, I would just like to reflect with all of you on the fact that with Medicaid, the Medicaid program that's now in its 50s, the Medicaid program has throughout its 58-year life always shined a light on some of the most challenging issues that we face as a country, as communities, and the most challenging issues that vulnerable populations face. We have seen it through the health insurance crisis of the 90s. We've seen it at various points when our safety net has been singularly stressed. We see it now in connection with the opioid crisis, what is emerging, as we all know, a behavioral health crisis in all of our communities. The behavioral health crisis, of course, is not means tested. We all know people. We all know that people are stressed. We all see the behavioral health issues in our families, in our communities. But the thing about Medicaid that's so interesting is that while it shines a light on these issues, Medicaid nationally has often been a focal point for solutions. Here in California, Medi-Cal is no exception. Medi-Cal has always shined a light on our most significant challenges, and hopefully Medi-Cal, through the superlative leadership of folks like Melissa, Medi-Cal and the programs that we offer in California will be part of a solution, particularly in connection with behavioral health issues facing children and youth. So with that, please join me in a warm welcome for our keynote today. Let's go back.
Good morning, everyone. It's great to be with you. I want to give a special shout out to John in the back in the AV. We just loaded my slides 60 seconds ago, so thank you, John and team in the back, for quick and handy work. Really appreciate that. I'm really pleased to have the opportunity to be with you this morning to tell you a little bit about the work that we are doing with the Children Youth Behavioral Health Initiative, but then even more to be in conversation with Margaret about that work, about some of the ways that we are approaching that work. And I think if there's time, we're going to have some time for questions from the audience as well. So it is really an all of the above, all sector, all hands on deck approach to supporting the behavioral health and well-being of California's children, and so I appreciate the opportunity to focus on this work this morning. Oh, let's go to, okay, right. So this first slide, you already all know this, whether you know it from your professional work. As Margaret said, we know that behavioral health issues touch many of us personally as well in terms of our families, our friends, our neighbors. I am no exception to that. And we also know, though, that there are some groups that are disproportionately impacted in terms of our children and youth facing behavioral health challenges. We know that behavioral health issues can affect all children and youth and do, but we also know that our BIPOC youth, our LGBTQ+ youth, our youth from low-income and underserved communities face both greater mental health and behavioral health challenges, but also more structural barriers to both accessing services and to the factors that we know support well-being. The good news, though, is that we also know there are things we can do. There are both strategies related to prevention and early intervention that can really make a difference in the lives of our children and youth, and that's the work that we're all deep and hard at work at together. So last summer, a little less than a year ago, Governor Newsom announced his master plan for kids' mental health. This is a cross-sector, multi-initiative, multi-billion-dollar, all-of-the-above approach to supporting and improving mental health of children and youth in California. It is intentionally cross-sector. The Children and Youth Behavioral Health Initiative is at the core of the governor's master plan for kids' mental health, but under his leadership, it is really also intentionally taking a wide cross-sector approach. So it includes work that's happening in K through 12 education with the Community Schools Initiative and other programs. It includes all of the work Margaret referenced that's happening in our state's Medi-Cal program through CalHHS, really thinking about how community-based services and the social determinants of health can be supported for well-being. All of the investments that are happening in workforce, and specifically the behavioral health workforce, within the CYBHI, beyond the CYBHI and health, but also in the education space. So really taking this holistic approach to transforming the systems that support behavioral health and well-being for our children. So what is the Children and Youth Behavioral Health Initiative, which forms the core of the governor's master plan for kids' mental health? It's a 5-year, $4.7 billion initiative. It is intentionally a systems change initiative. We have heard loud and clear from our partners, and that includes youth, families, our partners with professional experience across sectors, that it's not a matter of just doing more of what we're already doing. That is not sufficient. That we actually have to change what we are doing to create a better system. And we're trying to reimagine what is that better system. And the work of the Children and Youth Behavioral Health Initiative is to create a more coordinated ecosystem of services and supports for well-being and behavioral health of children and youth. One of the things we consistently hear, the governor talks about this, the first partner talks about this, we hear it from youth, we hear it from families, we hear it from practitioners. Our systems are incredibly siloed. And those silos both create barriers to access, but they also create barriers, especially for children and youth, to early intervention and to more upstream work and prevention when there is that opportunity to do so. And so we know that our children's issues escalate over time because we do not intervene or provide prevention-oriented approaches as early and as much as we could. In addition to building a more coordinated system, the focus of the Children and Youth Behavioral Health is explicitly on building a more youth-centered system. We definitely hear our partners with professional experience talk about and recognize that it often feels like decisions get made about how youth and families access care or get supports that are sort of based on the proclivities of the system and not actually what kids and families need and want and tell us they need and want for their well-being. And so how do we actually create a more youth-centered system? So that is what we are trying to do in the Children and Youth Behavioral Health Initiative. And that deeply relates to the third sort of focus within the Children and Youth Behavioral Health Initiative, which is creating a more equitable system. As I talked about, we know some groups are disproportionately impacted, so we are taking a targeted universalism approach in the CYBHI, trying to set universal goals for all children in terms of their behavioral health and well-being, while recognizing that some groups face greater barriers and structural barriers to achieving those goals, and so we will need targeted strategies to advance equity. And then fourthly, we're really, the Children and Youth Behavioral Health Initiative works along the entire continuum of care. So thinking about prevention, how do we support positive mental health, early intervention, all the way for our children and youth that we know are struggling. Often system-involved youth with intensive clinical behavioral health needs. How do we do a better job at supporting them to get access to the full range of services and supports they need, and everything in between? So really thinking about that full continuum. But in the Children and Youth Behavioral Health Initiative, we do have a particular focus on, as much as possible, building a system that is prevention, early intervention, and well-being oriented. Because as I said before, we do know and we hear this. Probably one of the hardest days in the last 18 months for me in this role was I was on a panel with a mom who talked about her 7-year-old who was suicidal at school. And she talked about, since that child was 3 years old, having some struggles, having some behavioral health issues, and just not being able to get to the services and supports that she and her family needed. And then here, this child was in crisis. And that is what we have to do differently. We have to find a way to create coordinated, youth-centered, equitable prevention and well-being oriented systems that really meet the needs of children and youth. So how do we focus on that coordination, that accessibility, working across different parts of the ecosystem? It's not just within health and human services, it goes beyond that. Really meeting kids where they are. And other than home and family, where do kids spend the bulk of their time? In learning settings. That could be childcare, early learning settings for our youngest children, TK through 12 for our school-age kids, and for our young adults. We know not all, but many of them are in higher education, including our community colleges. So we're really working to meet kids and families where they are in the work of the Children and Youth Behavioral Health Initiative. Okay, I promise not to go through this. I call it the box slide though, it's on our website. And if any of you have had a chance to visit the Children and Youth Behavioral Health Initiative, we're working on a new website. I get lots of feedback that it's hard to find things. We don't disagree with you, so we are hard at work on a website that will provide you, I hope, with easier ways to find information about, we call these the work streams. There are 20 of them. I think of them as the tools we have in our toolbox of the CYBHI for achieving that vision I just described of a reimagined behavioral health ecosystem for children and youth in California. So these are the tools we have to increase coordination and integration, youth-centeredness, equitability, and a more prevention and well-being oriented system. These are a combination of policy changes, state budget investments, across these 4 main focus areas you see. And I'm just going to focus on the 4 main focus areas, but in the Q&A, if there's a particular work stream that you want to know a little bit more about or have a question, please ask me. So the first area of focus is really on workforce. We know that we need to build a larger, more representative workforce that speaks the language, comes from communities, and understands the experience of our children and youth. That's what they tell us they want and need in order to access behavioral health services and to increase the capacity and capability and training of the workforce for that effort. The second is really around building the ecosystem infrastructure that we need for this reimagined system. And this is a combination of factors. It's investments in bricks and mortar, because we know there are certain kinds of services we don't have enough of. It includes investing in the partnerships that we know are critical to a more coordinated system. I was on the phone just the other day with a leader in K through 12 education who was talking about the work that's happening through one of these work streams to build partnerships and joint intervention efforts between Medi-Cal managed care plans and school districts. And the point he made to me was the power is not so much, although it is great in some of the specific targeted interventions they're doing together right now, it's that they did never have any relationship before. There was no relationship between the school and the health plan, and they are forging that relationship, which they can see is going to serve them well in terms of building a more community, cross-sector approach to supporting the well-being of kids going forward. This also includes scaling evidence-based and community-defined practices, developing a virtual services platform that will have a range of both information and resources and self-management tools, but also online access in a safe way to behavioral health coaching and counseling, because other than home and family and school, we do know that another place kids are is online, and we want to provide a safe, information-rich resource, and we're working really hard actually with youth in particular themselves to help design and develop that virtual services platform. The third area of focus in the Children and Youth Behavioral Health Initiative relates to coverage. And in particular is this fee schedule for school-linked behavioral health services that will apply to both Medi-Cal managed care plans and commercial health plans. And this is so important because what it does is it provides a point of access. We know that when behavioral health services are offered in schools or in a school-linked setting, youth are more likely to access them. And so this is meant to provide financial support in an ongoing way. It's a 5-year initiative, but this piece is ongoing. Ongoing financial support to schools for school-linked behavioral health services for students, for all students, those with both Medi-Cal and commercial insurance. And then the fourth body of work is really around public awareness and reducing stigma. We continue to hear from youth that stigma remains a barrier to getting the supports and services that they need, particularly early on. And they recognize, and they often talk about how a lot of the stigma, it is amongst their peers, but it's even more in their families and communities. And they understand there are a variety of reasons for that, and that we need a really focused, culturally respectful and relevant way to work on stigma and raising awareness about behavioral health issues and how we can support our kids. These are just a few things that I want to point you to in case you want to learn more. We did a progress report in January, so there's a little bit of information and update on our activities on all of the work streams. We published a report. We did a lot of youth, family, and community engagement in 2022 to lay the groundwork for the initiative, and we synthesized that into a report called Youth at the Center, if you want to see those findings. We also wrote a paper, which I think Margaret and I may have a chance to talk a little bit about how is it that we actually make this idea of a more coordinated ecosystem real in practice. What would that take? What would it look like on the ground? That's our ecosystem working paper. And we've had a CYBHI equity working group that's been working over the last year to develop a working definition and a framework for embedding and advancing equity, including a toolkit, which we will be, the group's wrapping up with its last meeting at the end of this month, and then we'll be publishing that on our website. Lastly, I'll close with, we of course are doing an evaluation of the Children with Behavioral Health Initiative. Mathematica is our evaluation partner. It's a multi-layered evaluation, really helping us to understand what progress are we making in terms of systems change, implementing the policy changes in the initiative, what difference are we making at a programmatic and population health level, but not in the sense of let's do a report at the end of the 5 years and then think about how we did. We're really trying to find ways to use CQI, rapid cycle evaluation. One of the challenges, of course, is data, how to have data in a quick enough time to make adjustments, but that is something we're working hard with Mathematic on so that we can learn and adjust along the way to have the most impact possible. And then these last slides are just resources for you. I think these will be shared. We do quarterly public webinars. Our next one is June 9th, where we update across all 20 of those work streams. We also do monthly written updates if you want to get on our mailing list for that. And each of the departments who's leading different parts of the work of the implementation of the CYBHI, they all have email boxes in case you had questions about any of that. So with that, I'll wrap up there and look forward to the conversation.
Thank you so much, Melissa. That was fabulous. So a couple of things that I think would be fun for us to talk about, and then of course invite questions from all of you. I'm struck by the authenticity with which you've talked about, both this morning and in other settings, listening to families, listening to their challenges. After all, when you're about systems change, it is imperative to hear from the critical audiences. Everyone in this room, virtually everyone in this room, understands how challenging true engagement, true authentic engagement is, particularly with people who are either in crisis or in a vulnerable setting, or suffering from various and sundry disparities in their everyday life. I'm wondering, Melissa, would you talk a little bit about the lessons you've learned about authentic engagement through this initiative, things you thought you knew and maybe learned a little differently? I think everybody would be very keen to hear observations about real engagement and what that takes. Thank you.
Sure, yeah, I'm happy to share with the recognition that it's a work in progress. So we actually started in early 2022 because we knew that in order to build a more youth-centered system, we were going to have to deeply engage with youth and families in really understanding what they wanted and needed out of a reimagined behavioral health ecosystem. And so we actually did a set of expert interviews with youth and family engagement organizations across the state and basically said, tell us the do's and don'ts. And they actually had a lot of common themes, including state of California, don't do this yourself. You're not trusted. People won't be honest with you. Work through trusted partners in the community. So a lot of the work we have done in terms of youth, family, and community engagement, we have done through trusted partners that are known to communities on the ground, known to families and youth, are working with them all the time, and so involving them in that work. They also said you need to be explicit about what the engagement is about. Some of you may have seen there's different models of it, but there's a basic slide that shows sort of an engagement ladder, right? All the way from sort of tokenism, all the way to shared power and co-decision making with many steps in between. And they said you really have to be honest with those you're engaging about how you're engaging them and how the information is going to be used. Are they helping to co-design something, or is it more of a consultation model and you're taking input, but then there will be sort of a process where you're deciding without them at the table? So really being explicit around how the engagement is done. Youth were very clear that they wanted youth-only spaces, as well as they wanted to be in spaces where they were at the table with decision makers. They also really talked about the importance of compensating youth and families for their expertise. And also really thinking about it as not being one way, really thinking about it being multimodal. So not just doing focus groups or not just doing it one way, but really thinking about a range of ways. And then the last, which is one of my personal favorites, is we often hear about, particularly for youth, the need to do different kinds of training so that youth will be ready to engage in the issues. The youth groups were very clear that it's the adults who need training, because when they come into the room, they know that adults don't really listen to them. And so they said, you need to train the adults in the room to really hear what we are saying and take it in. And we've worked with some partners on this who have talked about it. How do you really take the spirit of what's being said so you can apply it authentically to the work? And this is a challenge, right? I mean, I think the most common kind of engagement is sort of the consultation input model, right? We listen, we take the input we feel we can use, we do our best with it, and then we move on. And I think we're really trying to think about how do we work at different parts of the engagement ladder based on what the opportunity is, what the needs are, what the timeline is. We actually just had our first meeting at the end of last week. We have formed a table of youth and family engagement organizations for this very purpose of helping us to think about how do we strengthen and build our capacity as an initiative. So all the departments who are working on the initiative are also at this table. How do we strengthen and build our capacity for youth engagement work? Basically, how do we do it deeper, more authentically? What does that look like? How do we hear from our partners what that would look like, and how we can build on the work that what we've done already? Because what we hear from them is very powerful. I mean, we did this series of youth and family and community engagement sessions last year, and as I mentioned, we have that Youth at the Center report, and if you look at those findings, they are calls to action from youth and families and communities, and many of their findings are quite profound. I mean, they talk about how culture is healing. They are asking us to redefine treatment. In their mind, they include and talk about the importance of clinical therapeutic services when that's what's needed. But for young people, they talk about treatment for them includes peer support. Mm-hmm. It includes access to safe outdoor space. I mean, I have to tell you, one of the findings that I did not anticipate when we started all of the youth and family engagement work is, especially with youth, how much they talked about the importance of nature, outdoors, access to green space, access to parks. I mean, I was at a roundtable of youth in LA, and they talked about the challenge is their neighborhood is not safe to walk to the local park. And so how could that neighborhood be safer so that they could get to their local park? a group of youth in the Central Valley who talked about their schools grounds get locked up in the evenings and on the weekends. And they know that in the higher income neighborhood up the way, that's not the case. So they see directly the inequity to the things that they are telling us support their mental health and well-being. And we see this youth engagement work as critical to the equity work of the initiative. We cannot address the inequities unless we are really hearing from a very diverse group of youth about what their needs are and what they want to see in the ecosystem of services and support, so that we can work on building that and develop strategies that really support that.
That is so profound for what many of us do in terms of seeking engagement, seeking input. Thank you very much. It makes me, you talked about the exercise of bringing youth to the table with the departments that are engaged.
Yes.
And I think that's a secondary or a component part of the stakeholder engagement process, meaning getting from the consumers and the families what they really need, and then imparting that to the departments who will experience, I would imagine, some fairly significant system change and internal departmental change. Does that resonate with you, Melissa?
It does, and I have a colleague who says, we are not taking the approach of if we build it, they will come. For those of you who are old enough to remember the Field of Green movie, we're not taking that approach with youth. We're not just saying, oh, we'll just figure, we're going to do it our way, what we think is best, and then we expect youth to come. We're trying to do the opposite of that. So yes, you're exactly right, and it's small examples to big ones. A small example would be, we're adding a new role to the behavioral health workforce that we originally called a behavioral health coach. And this is really meant to address some of the gaps that we know we have in the workforce ladder, where we have positions like community health workers, peer support specialists, where you might need a high school diploma. And then there isn't a lot in between until you get to a master's level clinician. And so really sort of building out that ladder, but also really reflecting what we've heard from youth, and this is very much of a near-peer kind of model. But youth were pretty clear, they didn't like the behavioral health coach terminology. That did not work for them, it didn't resonate. And we surveyed them and they asked us to change it to wellness coach, so we now call it a wellness coach. That's what youth wanted us to do. So that's a small example. A larger example, as I mentioned, the virtual services platform the Department of Healthcare Services is building and designing. And they engaged youth all along the way in terms of what should be on the platform, what it should look like, how it should be designed, how services would be accessed. They reviewed different proposals and prototypes. Youth were very involved in how is that platform going to work, because it is meant for them. If it doesn't work for them, they aren't going to use it. And so, for example, youth were really clear in the platform that they wanted to have a certain look and feel they're used to, a little bit like, a social media, but they don't want it to be like social media. They don't want likes and dislikes. Mm-hmm. They don't want to feel judged. They want it to be a safe, supportive space. So it will include, for example, peer-to-peer supports, but it will be moderated peer-to-peer support on the platform. So really being designed in a way that youth are telling us they want and need.
Oh, that's fantastic. Now, I know that we're not taking the Field of Dreams approach. You build it, they will come, and you are going to be iterative and respectful of all the inputs. I would imagine, though, concurrent with that, which seems the absolute perfect way to go into system design in an authentic way, do you have ideas about, if you had a crystal ball at this stage of things, do you have an idea of, if not what end state, future state looks like, what end state, future state will generate?
Yeah. Yes. Absolutely. So we've been working on establishing a set of 5-year outcomes goals, and some of you may have seen them. We've shared them in draft form and in a number of forums to take input. We actually developed our 5-year outcomes goals through a series of workshops and engagement and listening sessions with youth, families, and communities, but also with our partners with professional experience, both in health and education. So we have a set of about 15 outcomes goals that are both thinking about different kinds of population health metrics. So really thinking about access issues, well-being, reducing some of what we know are the serious clinical behavioral health issues. What are we seeing of that in terms of prevalence? But also systems change measures. How are we really understanding if the system is becoming more coordinated, if it is becoming more financially sustainable? So we do have a series of outcomes goals in that way. What's really key though is we all know big systems change outcomes goals, it is hard to see them in less than 8 to 10 years. Mm-hmm. It just takes that length of time to both move the needle but also see it in the data. So that is why we're working really hard through our evaluation work with Mathematica to do, we're really trying to take a cascade approach. So we're trying to think about what are those big outcomes goals that we're working to refine, but which were really sourced from the field in terms of what people said were the priorities that most needed to be different in terms of the outcomes of the system. And then think about, in those 20 work streams, how do we design and implement those work streams and look at the goals and objectives in the nearer term for those work streams that will help us understand if we're moving toward those outcomes goals. And that will be both a combination of quantitative and qualitative work. We really do plan to continue to engage youth and families and communities as part of our evaluation work. We have an evaluation advisory group that's a combination of youth, families, frontline practitioners, local systems leaders, and also researchers and data smart people types, all together as a part of an evaluation advisory group. And so we really will have a combination of a quantitative and qualitative approach that will help us know, are we at least directionally heading toward those large outcomes goals that we may not see change in the data for a number of years, but how do we really make sure we're understanding our progress, or candidly, if we're not making progress on that work, how do we do that? And I think that, at this stage, I think one of the most promising sort of shifts in terms of that outcomes goals is what we are seeing is really increased effort between health and education. That is something we're working really hard on. I think there are a lot of relationships at both the local and state level that are emerging in terms of how do we really come together to support behavioral health and well-being for our kids. I mentioned one of the work streams that's already between Medi-Cal managed care plans and schools, but there are a number of others working in that space. We are, for example, really thinking about how do we support coordinated implementation of the Community Schools Initiative in K through 12 education and the Children and Youth Behavioral Health Initiative, because they have a lot of features in common. They're whole child, they're equity centered, and they're focused on well-being and thriving, all with a systems approach. And all with a strong focus on centering youth, family, and community. So rather than having those initiatives be implemented in silos, because our goal is to bust silos, not to create them, I say I will have failed at my job if those 20 work streams end up being 20 great programs that are completely siloed. I will have just failed. The work is to create a more integrated, coordinated system. So how do we continue to do that, but then how do we actually know? And so we're really thinking a lot about the systems change work in combination with really looking at access metrics and population health metrics over time.
Thank you. Thank you so much. I have a couple more questions. I don't know if anybody in the audience would like to pose a question. Please feel free, raise your hand. One thing that occurs to me, Melissa, is that, again, as the future state evolves, it strikes me that we will face the challenge, the opportunity of developing new types of workforce categories, which will be exciting, don't you think?
Yes, I do. Yeah, I mean, workforce is an issue, right, for our whole healthcare system, and including in behavioral health. And I probably have not been at a meeting or a convening in the last 18 months where workforce has not come up, because it's a key rate limiting factor, right? If we don't have the supports for youth and families, then we cannot deliver the services even if we have the most perfectly better designed ecosystem and set of systems. So workforce really is critical, and I think we are really trying to hit it sort of on all cylinders. So there's significant investments in how do we just increase the number of behavioral health workforce providers that are sort of our more traditional clinical providers that we know we need more of, and we need a more diverse representative group. And that different youth and families, in terms of their identity and what's relevant for them, that they can have that experience of having somebody who understands them for the clinical and therapeutic services that they may need. So really, scholarships, loan repayment programs for, psychiatrists, nurse practitioners focusing on mental health, psychologists, the full range, social workers. But then also really thinking about the expansion of the workforce. And I mentioned we've heard a lot from youth around their real interest in peer-to-peer support. So this new wellness coach model is like a near-peer model. And we're really hoping to attract young adults into that field and into those roles to, as when I was in a group with youth who are a youth advisory board for a school district, and they very kindly said, with all due respect, Melissa, you are not the person we want to see when we walk into our school wellness center. You're a middle-aged white woman, you're not what we want to see. We might eventually be willing to talk to you if you were a counselor or a therapist, but it's not who we want to start with. We want to see first somebody who understands our experience and comes from our own community in, say, a school wellness center. And so how do we really build out that part of the workforce? And then we are also working directly on peer-to-peer supports. We have a $10 million pilot looking at peer-to-peer programs in high schools and really understanding what is sort of the best practice guidelines for those programs, so that as schools look to potentially increase those, because that is what youth are asking for, that we have really a set of guidance documents and toolkits around what best practice high school peer-to-peer programs look like. But yes, investment in the workforce is a really critical piece. And we have parallel investments happening through education. So for example, in California, we have Golden State Teacher Grant Program that last year was expanded for school-based behavioral health professionals. So now school-based social workers, school counselors, school psychologists all have access to up to $20,000 scholarships to support their training and education.
That's fantastic. I think everyone in the room, in their respective work, in their organizations, and in their specific field, certainly experiences the workforce imperative on a daily basis. But in this context, particularly relating to the goal of system change and the authenticity with which you're engaging all the stakeholders, the ability to build and respond in a meaningful way seems incredibly immediate, which is exciting. Question about the extent to which we might be able to expect or see broader messaging through media outlets, and the push for us as a community, as a state, as stakeholders, the push for us to collectively destigmatize.
Yes.
We all know, again, as I mentioned at the outset, of course, we all know that behavioral health challenges, mental health issues are never means tested. They do, however, have disproportionate impacts on vulnerable populations. But for as long as I can remember, we have been talking about stigma and the pernicious impacts thereof. So can we conclude our comment or talk and invite everyone to join in here? What we can all do collectively, or what we can think of as best practices in this foundational issue. Thank you.
Well, thank you for that question. I think you all know May is Mental Health Awareness Month. So obviously we're working on mental health awareness and reducing stigma the whole year round, but May is a special time of focus, including earlier this month we had Children's Mental Health Awareness Week. But I do encourage folks on our website, we do have a toolkit, so I encourage you to look at that toolkit, and if there's any opportunities for you to share some of the key messages around reducing stigma and that it really is okay to ask for help. We're really encouraging that work as part of May as Mental Health Awareness Month, and some of you may know tomorrow is Mental Health Matters Day, and so there'll be events at the Capitol around that as well. In terms of specifically in the Children and Youth Behavioral Health Initiative, as I mentioned, we have sort of one of the 4 areas of focus is really around raising public awareness and reducing stigma, and we're taking several different approaches to that. As well as I think it's really important to say that the work around reducing stigma doesn't only come in the public campaigns. We think it's really important to the design of the entirety of the initiative. So for example, I think that even the creation of the wellness coach role is a really important stigma reduction strategy, that somebody who comes from my community and looks like me is working at the wellness center and is here to talk to me about what may be going on with me and what some of my needs may be to support my mental health and well-being. Or it has to do with how we design access to services, right? In terms of how easy we make it and how do we remove some of the barriers that make people feel like there's a stigma associated with accessing services and support. So we're really trying to think about that across the entirety of the design of the initiative, and then with specific work related to campaigns. So we do have a California Department of Public Health is developing a $100 million public awareness and stigma reduction campaign specifically focused on youth and families. And that work will deeply involve work with youth and parents and families, because we know that just one approach or just one set of messages is not going to necessarily address. We heard in our work with youth and families, for example, that in some communities there are very specific issues, right? Whether they are rooted in structural racism, whether they are related to immigration, right? Whether they are related to LGBTQ plus status, right? In different communities, we have to think about what are the messages that are going to really speak to the needs and issues and challenges of various communities, and we need those communities to tell us both what those issues are, but what way of approaching them is going to be relevant and meaningful to reducing stigma. And some of it is just to keep talking about it. I was at a school in Los Angeles County, I think it was 2 weeks ago now, including meeting with a group of parents, and one of the moms just said, you know what, she basically said, I had a lot of stigma around mental health and my child needed support and I was having a really hard time with it. And what she talked about was the school just kept including it in everything. In the school newsletter, in the emails that went out, in the services that were available on the campus, in different forums she would go to, education forums for parents or sort of parent gathering groups. She just said it just was, and over time, not just for a month, you know, not just for one school year, it was ongoing. And she really talked about how that has been critical from her perspective of increasing her understanding of mental health issues and breaking down some of the stigma that she had, and that was, it was done in a way that was really relevant to her culture and her concerns. And so that stigma reduction campaign, and it's not just a stigma reduction campaign, right? Because ultimately what we want is to support youth and families in getting access to the supports and services they need. So how do we both break down stigma, but also hear from them, what do they need to then take that next step of reaching out for help? So really that is, there's that work happening. And then also through the Office of the Surgeon General, we're doing a campaign related to ACEs and toxic stress, and really working with families and communities to think about how ACEs and toxic stress affect mental health and what are some of the strategies and what's already working in communities, right? We know communities are incredibly resilient and actually do know what works for them. How do we tap into that? How do we support that through the campaign? And then also a strong focus on parents and families. And then the other really important campaign that I think is partly stigma reduction, but also goes beyond that, is we have a campaign that's focused on a targeted approach to youth suicide prevention. And really, we've been looking at the data for what groups are at highest risk of suicidality, and really thinking about how we're going to develop a targeted campaign that's a combination of a campaign, but also grants in communities to reach out through trusted partners in those communities to work on youth suicide prevention.
Thank you. Thank you. Any questions from the audience? I think it's a perfectly... Oh, thank you. I'm sorry. Okay, great. Thank you.
Thank you. Good morning. My name is Christine McCoy. I'm with the Stewards of Change Institute, and by context, I'm a family physician, and at one point was the child and adolescent coordinator for federal HHS, way back in the Clinton administration, so a while ago. My question for you is, what are you doing to facilitate the legal and efficient flow of information between all these silos that you are talking about, and explicitly when the consent of either the parent or the youth is required?
Yeah, such a great question and a big one. This is something we've heard from our partners in the field extensively. The information sharing is possible, but it's challenging, and candidly what's happening right now is every community is trying to figure out how to do it on its own. And so we have a process at CalHHS called the State Health Information Guidance. It was a new acronym I learned several months ago, SHIG. I hope you'll hear more about it. I hadn't heard of it before. But we actually are in the process of selecting a project management firm to lead a SHIG process that specifically looks at this issue, particularly related to HIPAA in our health context, FERPA in the education context, and the role of consent. This is guidance. I want to be clear. It's not regulatory requirements, but it is guidance that we hope will provide sort of a framework at the local level for folks to make sort of final decisions about how they are going to structure their relationships and information sharing, but that specifically addresses, and it uses a scenario-based model, so it's not just a sort of 10,000-foot level. The process itself and the guidance will be derived from looking from a technical legal expertise perspective at a series of scenarios in the field to develop that guidance and share out with the field. So we'll be working on that in the coming months.
Thank you. One more question.
Don't get me in trouble. Make it great, but okay.
Thank you for a great discussion. My question pertains to the entry point especially in primary care. I think we're discussing sort of the services that are available and coordinating and connecting the silos, but often there's a lot of missed opportunities in the primary care setting where a youth comes in with a condition, and there's a missed opportunity to identify a behavioral health, mental health issue, often manifested as a physical ailment. And even there's some stigma in some instances of a behavioral difficult child. What is being done to support, outside of education, support primary care providers to ensure that there's enough resources available in the office to ensure that proper screenings are being done? And often these conditions, take a little bit longer than to take a blood pressure check. There's questions, etc. So what's being done? What are your thoughts about supporting the primary care workforce to identify in its earliest forms and then properly refer and follow up these conditions?
Yeah, thanks so much for that question. And we didn't talk a lot about the primary care intersection today. So it's a couple of things. One is a component of that virtual services platform that I mentioned is taking an e-consult program statewide, so that our primary care providers, our pediatricians, will have access to experts, behavioral health experts, both asynchronously and synchronously for that consultation model. So really trying to increase access to behavioral health experts for our primary care providers and pediatricians who are serving youth when they tell us they are increasingly seeing children and youth in their practice with behavioral health needs. We also, as part of the CYBHI, added a new dyadic services benefit in the Medi-Cal program, if you're familiar with that, which is a really critical benefit in terms of addressing behavioral health but in the dyad, recognizing the supports that a family may need. So there's a full range of services that is part of that dyadic care benefit. And it is for children of all ages, but we know it's particularly important for our youngest children as well. And then there's a lot of intersection, and we work regularly with our partners in the Department of Healthcare Services implementing CalAIM, of course, because we're the work that's happening in the CalAIM program, both around behavioral health, but also around both primary care behavioral health integration work, but also thinking about prevention and screenings and how we increase follow-up and coordination of care through CalAIM. So I think there's some really important intersections between that initiative and CYBHI as well.
Thank you. And thank you for the great questions. Thank you, everybody. I think that this conversation has been incredibly thought-provoking. I hope that you will join me in a moment to thank Melissa for joining us this morning. But I would just close with an admonition and a recommendation that we take to heart something Melissa said a few minutes ago in the stigma conversation, that we keep talking about this, that all of us in all of our domains keep talking about this incredibly important issue and the initiative. So please join me in thanking Melissa. Thanks.